So one of my areas of interest is the effect of WM and our IgM neuropathy, IgM on the peripheral nervous system. And I'm very privileged to work with Professor Mike Lunn at Queen Square in London, part of our trust, where we sort of go into these conditions in some detail because there's a lot of unmet need out there for these kinds of conditions. So to start with, I just want to let you know that, it's quite small. The overview of the talk is going to be about the symptoms experienced when you have peripheral neuropathy, why it develops, and a little bit about how to manage these different conditions and how you can perhaps help yourself to manage as well. So a very brief tour of the nervous system, because I think that can help you to navigate the problem and what's going on. This diagram is a picture of the nerves, really, the peripheral nervous system, which all emanates from the brain and the spinal cord. And the brain and the spinal cord are known as the central nervous system, and the rest of the nervous system is the peripheral nervous system. And there are these so-called cranial nerves, which are 12 pairs of nerves that arise from the brainstem area and give rise to they supply the head and neck area and carry out a lot of functions, including movement of the face, the muscles, chewing, swallowing, etc. So if they go wrong, then you do tend to get symptoms up in the head and neck area. And then there's 31 pairs of spinal nerves, which come out from the spinal cord through small little gaps between vertebral bodies, and they then go on to supply different parts of the body as well. And some of these nerves are very long. And the reason I mention that is because a nerve arises, there's a nucleus in a cell body, and if you have a very long nerve, whatever nourishment and maintenance goes on in that nerve has to be sent all the way down that nerve. And so when there are damaging problems happening in the system, this is why sometimes the end of the nerves get affected first, a so-called length-dependent neuropathy.
Yes.
So this is a picture of the anatomy of a nerve. Now, it's all about electricity, but actually deeper than that, it's all about movement of electrons, because electrical charges is what propagate through nerves to pass signals on from the brain to the periphery and from the periphery to the brain. If there's anything that interrupts that, then there is trouble, and that gives rise to symptoms of a varied nature. It's quite an anatomical subject, neurology, because different nerves supply different parts of the body. So when I'm in a clinic with Prof. Lunn and he does an examination, he can make quite a good estimate of where the problem is likely to be. And then that's followed by relevant investigations to confirm or refute that. So you can see that there is So there is the wire of the nerve called the axon, and it's covered by another series of nerves called the Schwann cells to form a myelin sheath. And this has the job of protecting and nourishing the nerve, but also helping to make electrical impulses jump very rapidly through the nerve as it goes along. And then there are many of these bundles, which, if you see the cross-section, you can see that they all bundle together to form the big nerve. And there's a lot of blood supply to the nerves. So any of these things can be affected, and that can give rise to nerve problems. There's another bit of the nervous system that most of us don't really know about because it just ticks away in the background, and it's called the autonomic nervous system. And another way of thinking about it is like the automatic nervous system. It just carries on doing things for us. There's two main areas. One is the so-called fight or flight part of the nervous system called the sympathetic nervous system, which regulates blood pressure, pulse, flow of blood in different organs. And it gets you ready for, I guess, back in the day when there were kind of mammoths and everyone chasing us around, it was like, get up and go, run, everything's ready to get you, to save yourself, really. The rest and digest side of it, the parasympathetic nervous system, helps with all our other functions, such as digestion, and it's more the so-called, you may have heard about the vagus nerve. There's quite a lot on the internet about how you can get your vagus nerve going. And that's the area that's the bit of it that helps to relax your system. So when, if the autonomic system goes wrong, then these areas of our functionality are affected. Very difficult, though, to pick up quite often. So if you do have a neuropathy, there are a number of things, it's quite a big subject and there's a lot to think about. But as a patient, the things which can really help you is to kind of write down, if you're going to see a doctor, have a little think about how the nerve problems affect you. So when do the symptoms start? Do they come on gradually or quickly? Has it been days, weeks, months, years? Because the tempo, I think, is really helpful in the diagnostic side. Is there a timing linked to any medication that you are on or any previous treatment you've had, such as anti-cancer therapy, some of which can cause neuropathies? How are you affected? Which bit of your nervous system is causing you the problem? Is it sensation? Is it pain? Is it balance, tremor? The nervous system gives out it speaks in certain languages. So kind of make a record so that it's clear and you can describe it. Is it asymmetrical or both sides? Is it just one leg, one arm? I mean, how is it? And what makes it worse? Is it worse in certain positions? Standing better than sitting? Do you get it when you're lying down? Does cold temperature make it worse, for example? And what helps? Do certain positions help? Is it rest, medication, and so on? And generally, how are the symptoms impacting on your function? Is it getting worse over time? So I think this is actually really helpful to doctors when they see you in the clinic, because most of the time you will see a hematologist and they will have a certain feel for nervous system problems. But if you can present them with a story and some details, if they then go and speak to a neurologist, they can then pass on that information more clearly. And it just smooths the process, which I think is always helpful. So neuropathy and WM coexist very often, but the fact that they coexist doesn't mean one is causing the other. And that is really important, because if WM is causing a progressive neuropathy, that's an indication to possibly treat. But if it isn't, and it's just a coexistence, then it's best not to treat, because once you give immunosuppressive therapy, you can't take it back. And there's a bit of, there's a sort of a legacy of chemoimmunotherapy. On the other hand, if it is causative of the problem, then it's important to prevent progressive nerve damage. So early diagnosis is very important. So this is the kind of way that WM and IgM interacts with the nervous system and the consequences that may arise. So there is the IgM in the middle, which is a protein that can give rise to inflammatory neuropathies because it can hang on to certain proteins on the myelin or attack nerves. It can have what's called cryoglobulinemic activity when the antibody crystallizes in colder temperatures and causes a sort of inflammation of the blood vessels, which can affect the nerves. Some of the fragments of the IgM, the light chains, can form amyloidosis, which can be a progressive problem which needs to be identified and treated aggressively. And then there's the more cellular aspects where the cells may end up in the wrong place, such as when Dorothy talked to us earlier today, the Bing-Neal syndrome. And the IgM problems can happen either when the WM is quite active and needs treatment, but it can also happen when things are seemingly quiet and the neuropathy may be the only feature and that may be an indication for treatment. I have to say this time, I'm not going to spend any more time on Bing-Neal because there isn't time, but in the panel, if there are questions, you can please do ask about that. So there are a number of tests to help figure out which bit of the nervous system is a problem, and they include nerve conduction tests, where needles are put in at certain areas. So, there's EMG, which is electromyography, which is where needles are put into muscles, but there's also electrodes that can be applied near sensory nerves to measure how things move, how quickly, whether there's strange patterns, etc. The important thing to remember is, A, they're often hard to do because there's a long waiting list. And secondly, it's not the kind of quality of it's very operator dependent. So one has to supply the person the right information, and the interpretation has to be done very carefully. So the EMG, or nerve conduction tests, are very useful to identify whether there's a problem with the large nerve fibers. Now, we often see patients who have a lot of pain and they have a nerve conduction test which is normal. And that's because small fiber neuropathy is not picked up on nerve conduction tests. So it doesn't mean you don't have nerve symptoms, but it may not be a large fiber neuropathy. And you may need serial studies to give you an idea of trend, of whether things are changing over time. A single study may not tell us too much. The other thing we sometimes interrogate is the central nervous system via a lumbar puncture, which is taken from the back of the spine, lower down, under local anesthetic. Here we take some of the fluid, the cerebrospinal fluid from the back, and send it off for analysis. And why might we do that? Well, we do it to look for evidence of inflammation, not so commonly infection, although that's probably the most common reason why lumbar punctures are done in medical practice, meningitis and such like. But for us, it's more looking for cells, whether there's any WM cells present. And there are ways of finding those. You can look down the microscope, but you can also use special tests to confirm whether those cells are actually lymphoma cells, so-called flow cytometry. And you can also look for markers like the MYD88 mutation. So we do this in certain cases. It's very important for that to be done after an MRI scan, because if you have an LP before an MRI scan, the MRI scan can look quite abnormal because all the meninges, the covering of the brain, lights up, and that can then give you false positive information. The other thing to bear in mind is if you are on a blood thinner or a BTK inhibitor, that can thin the blood, so it has to be stopped before you have an invasive procedure. And so if your team don't remember, because sometimes it's crazy, it's something to bear in mind yourself. And that goes for any procedure when you're on a BTK inhibitor like ibrutinib or zanubrutinib. There are many, many scans available nowadays, and they're very, very sophisticated. Interpretation is very important, especially for MRI scans, which can look at the nervous system in great detail. Sometimes CTs are used, just computed tomography, which is an X-ray-based scan, partly because if you have a pacemaker or something like that, then you can't have an MRI because the magnet. It's not absolute. Some pacemakers are MRI compatible, but the medical team should look into that. And usually, if we're looking at the nervous system, we give something called gadolinium, which helps to distinguish between different features in the tissues and gives a good idea of how the nervous system is working. So you can image the brain, the spinal cord, smaller areas, and that is done hopefully in a way that is based on the clinical suspicion of what's going on. So these are the so-called dermatomes, and I put this picture up to demonstrate the anatomy of the nervous system and why we sometimes, when people have symptoms in a certain area, it's important to remember that it could be mechanical. Lower back pain, degenerative change is actually very common in the general population. And I have to say, we've seen a lot of patients in our joint clinic who turn out they have WM, they have nerve problems, but actually it's nothing to do with the WM, and they probably may have a disc problem in their back. So that is one of the reasons the history is vital, clinical examinations super important, and then potentially scans. So it's really important to remember that as the nerve roots come out from the cord through these little sections between spinal vertebrae, they can get squashed by discs or by damaged backs. And that's something that we shouldn't ignore just because someone has WM. Because if that is the cause, then that should be treated. So what about nerve biopsies? So this is something that can be done typically from what's called the sural nerve, which is near the ankle. This is done particularly when the initial tests don't confirm what we think is going on. And there's still a concern about whether there's, for example, amyloidosis infiltrating the nerve or cells. or sometimes inflammatory problems like so-called vasculitis. They're not done very often, but we do them in a select number of cases. And again, it's a test that really needs to be done in an expert center, because the surgeon who does these tests needs to be very, very careful in how they handle the nerve so that they don't give it a good tug and a pull, because that distorts the anatomy. So again, it's a specialist test. It's done in selected cases, and it's the people who have it done are carefully chosen. But it is a test that sometimes is done. You can see pictures. It's probably not very clear, but these are sections of nerves. And the cross-section under the lowest picture is what's called an electron microscopy, which is really magnified. It shows how the myelin around the nerve has been separated by MAG antibodies. And we'll talk a bit about anti-MAG neuropathy shortly. That leads to a disruption of conduction and some of the symptoms that people have. So talking of which, IgM is an antibody, tends to circulate in groups of 5 or 6 even, and they sometimes misregister normal tissues as foreign. So there are a number of proteins and bits of lipid in the nervous system that the antibody sort of happens to come across and sort of mistakes it as being some sort of pathogen. And that can lead to a gradual degradation of those tissues over time. And some of these are called, the most common is called anti-MAG antibody, anti-myelin-associated glycoprotein. But there are a number of other antibodies, including antiganglioside, et cetera, which, again, is something the doctors would look through and make analyses of. Sometimes it looks like an anti-MAG antibody, but there's none on testing. And that is because we haven't discovered every antibody that exists. So there are oftentimes inflammatory problems, but we don't know what the target is. So we're not able to really clinch the diagnosis. Then we have to think a little bit outside the box and try and work out from first principles what's going on. So MAG neuropathy is quite a big topic. There's a lot of research in it. I think the key thing to remember is that if you have a neuropathy and your doctor tests you for anti-MAG, if it's positive, it doesn't mean it's anti-MAG neuropathy. It's really important to get a proper opinion, because anti-MAG neuropathy is typically symmetrical. It typically starts in the feet and gradually comes up, often sensory symptoms, weird numbness, strange feelings, also problems with balance, tremor, a certain kind of tremor, not like a Parkinsonian tremor, different sort of tremor. And it affects the legs before it hits the arms, because that's the length dependence of it. So if you randomly have arm neuropathy but nothing else, it's just not going to be anti-MAG neuropathy. So there are a number of patterns that help us make the diagnosis. There is an antibody test called a Bullman ELISA, which is a commercial test that's most widely used. Many of you may have had this test. It can cause a lot of concern because people think, well, it's positive, it must be a problem. But what I'd like to say is that rheumatologists who look after autoimmune diseases, they often, in medical practice, there are often autoantibodies found, but they're not always significant. So it's really, as I say, the connection has to be made per patient as to what's actually going on. If you do have anti-MAG neuropathy, when is it treated? Well, the simple answer is really when it is perhaps causing problems that are progressive. Otherwise, you shouldn't be treating them because it involves the use of drugs like rituximab or even other treatments like chemotherapy. Sometimes zanubrutinib, etc., are used. But sometimes anti-MAG neuropathy can take years and years to develop before you need to treat it at all. So again, it's an individualized decision. And the way one should treat it is it's not clear. Most times when an antibody is causing a problem, the sort of wisdom is to get rid of every last antibody possible. But in Waldenström's, it's really difficult to get the so-called complete response. So one has to be quite sensible about what we're trying to achieve. And for the most part, it's stabilization or improvement if we can, but also other things which I'll mention shortly. So very many treatments have been used, such as intravenous immunoglobulin. There's another condition called CIDP, which is often mistaken for anti-MAG. And the treatment of that is intravenous immunoglobulin, but it doesn't usually help very much in anti-MAG neuropathy, but it can sometimes delay the diagnosis. Steroids can be used, but it's not for a long time. It's a short-lived temporizing measure. Rituximab has been used, and then, of course, one can upgrade to other chemoimmunotherapy combinations. But the more chemo you use, as Prof. Busker said, the more the risk of toxicity. If people don't have anti-MAG neuropathy, but it's felt to be inflammatory, then again, we use similar principles, but it's a little more, it's a bit more vague as to what to expect and how to treat and which drugs to use, for example. So again, ideally working with a neurologist who's a specialist is the best way forward, but there aren't that many of them around, so that can be a problem. So as I mentioned, so sometimes anti-MAG neuropathy occurs when there's just an IgM paraprotein, but when you do the bone marrow, it's pretty clear. So an MGUS, situation. But there are times when it occurs in the setting of a bone marrow positive for Waldenstrom's. And that gives us food for thought, because if you have basically the antibodies being produced by the disease, so the question arises as to what extent do you suppress the disease to get a response against the nerve damage? So typically, if someone has progressive neuropathy in the setting of Waldenstrom's in their bone marrow, we would tend to give chemo plus the rituximab to sort of squash everything, turn off, shut down the factory that's producing the antibodies and hopefully give the nerves a bit of a break. So again, when we treat this setting, we follow the same sort of path as we do to treat Waldenstrom's. It just so happens that in this case, it's a nerve. Nerve is the downstream effect. The rest of the Waldenstrom's may actually be quite fine. Hemoglobin, everything may be fine. Yeah. So that's pretty much what I've said. A lot of treatments applicable to Waldenstrom's are applicable to the nerve setting. Certain treatments like bortezomib or Velcade can make neuropathy worse, so need to be used with caution. But there are some other proteasome inhibitors that are coming online which are less toxic. So there are different ways of addressing the problem. So in the lead up to this meeting, I had an email from someone from, I think, Germany, actually. And she asked a really good question, which was, and I'll read it, how does one weigh the effects of rituximab or bendamustine or ibrutinib or zanubrutinib on the immune system with numerous side effects versus living for some more time without treatment and risking possible irreversible nerve damage? Is there a way of measuring more objectively the level of disability caused by peripheral neuropathy and the point when treatment needs to be initiated? So I was actually very grateful for that question, because I think it's something that does bother both patients and doctors. I think the first thing I'd say is we need to get the right diagnosis. So cause and effect is important, number one. Second is, in our practice, if we think there's an association between the WM or the IgM and the neuropathy, we sometimes give it 3 more months before we jump in treatment. So see them again. What's the change over time? Is it, how is it affecting the patient? Can we wait or should we go ahead? And then thirdly, there are some new scoring systems which are increasingly used in inflammatory neuropathies, which is something the doctor can ask the patient and write down, called the Rasch Built Overall Disability Score, the RODS. And that's a good way of getting, you ask a series of validated questions, the patient answers, and then you can see objectively over time whether there has been a change. So we do that very routinely in our clinic, and sometimes we use that, we include that in our toolbox of deciding whether to treat or not. And other things, how quickly is it progressing? Is it impacting on function? What about intrusive symptoms like pain? How bad are they? Sometimes you can actually, if function is not being affected too much, but pain is a problem, there are many ways of managing nerve pain, which can be brought into the mix as well. So I mentioned this mainly to say please ask in the Q&A later if you have questions about Big Neil, because the time is short. So what else can you do if you have nerve problems? So I mentioned pain. There are many ways of dealing with nerve pain. Depends what's causing it. Sometimes if it's a back problem and a facet joint, you can have facet joint injections. If it's a disc, again, you may even need, physiotherapy, for example, is very important. You may need to see a spinal surgeon if it's really bad. Pain management, there are many medications which come under the antidepressant label or the anti-epileptic label, but they've evolved to be used for anti-pain medicine, anti-nerve pain medicines, because they kind of like all these anti-things in the nervous system just basically damp down the immune system. And one hopes that they damp things in a more positive way if you have pain. So although they come under the antidepressant kind of class, they're not really used to that anymore. And that includes things like amitriptyline, duloxetine, and venlafaxine. So these are quite often used, and you have to usually build up on them because they can be a bit sedating to start with, but in the end, you can normalize. And so with adjustment, you can sometimes find a way of being more comfortable with the help of your doctor. I mentioned anti-seizure medications, so gabapentin and pregabalin are the main ones that we tend to prescribe. And so again, there's a ramping up and an adjustment, and one has to sort of titrate the symptoms and the response. Mm. There are a number of topical applications, such as lidocaine patches, which is an local anesthetic. There's also capsaicin cream, which is like a chili cream, which sort of distracts the nervous system from the pain. And there are other things like the TENS machine, which can be used. The value of topical things is very individual, but sometimes it's worth trying because otherwise you may have to have polypharmacy, which is not desirable. Sometimes people do need opioid medication, i.e. codeine, oxycodone, morphine, but it's preferable to avoid these if one can, or use them for a limited time until you treat the underlying cause. There are muscle relaxants that can be used, such as baclofen. Spasms can happen, and that can make things worse. Diazepam can be used in the short term for muscle relaxation. If there's an inflammatory problem, steroids can help at times to reduce swelling around the nerves. Sometimes can be injected into certain nerve compression areas. And in terms of, what medication to use, one has to weigh up pros and cons of having it versus potential side effects. This is for symptom management. Exercise is obviously very, very important. And there are ways I'm not going to go into great detail. There's a session being recorded next door by an expert. But what it does in general is to increase your strength and endurance. It actually improves mood when you've done exercise, so that can help with chronic problems, increases your fitness. And there are many guides. It's great to have someone who's an expert, at least you can see once, like a physiotherapist or something like that, who can set you on a path which you then need to follow. Unfortunately, you can't have intravenous exercise. You've got to do it yourself and persist with it, but it can bring good benefits. So there's different ways of exercising, stretching. These are things I should do myself, actually. Balance training. And for those who do develop weakness in their feet or ankles, for example, there are a number of orthotic devices that can be useful and very important, actually. So if you develop foot drop, then an orthotic device can help to stop you tripping over, because that can lead to falls, of course. And again, the technology in orthotics is remarkable. There's so many of them now, and typically they are made to measure for your needs. So my take-home messages are to get advice and to get active. Thank you very much.